So good morning, everyone. My name is Shane O'Hanlon. I'm a consultant geriatrician at St. Vincent's and Loughlinstown and training lead with NDTP for the southern part of the IEHG health group. So we're going to Wexford for today's IEHG Grand Rounds, and you're very welcome, Alan Marnan. Alan is an SPR in gastroenterology. And Alan, you've got a team with you down there. So do you want to ask people just to say hello as well?
Yeah, I'll just show you the audience there. So I have Dr. Mike Reardon and Dr. Edna Harkin in the background here, two consultant geriatricians and a few NCHDs in the background as well. I have Luke Byrne over there, who's after a week and night, so be kind to him. He's a cardiologist here doing his GM here as well.
That's fantastic. And actually, we've just had an extra panelist join us as well, Jürgen. You're very welcome. If you want to unmute yourself and just say hello, people can see you then once you say anything. So you're a consultant colorectal, peritoneal malignancy and general surgeon. Is that right?
Hi, Shane. Yes, thanks for inviting me along. Yeah, I'm happy to comment on this case and to contribute to the conversation.
Fabulous. Thanks very much, Jürgen. And you're based in the Mater Hospital, isn't it?
That's right.
Brilliant. Okay. And we also have Tomas Breslin, my colleague, who's a training lead in the IEHG North. He might be joining us as well. So if you want to say hello, Tomas. He's online with us anyway. Great. Okay, Alan, you able to start sharing your slides? We can let you kick off then.
See that now before we...
Yep, we have that. And actually, just check we are recording as well. Yeah, perfect. Yeah. Okay, so you can take it away when you're ready, Alan. Thanks very much.
So I'm Alan, gastro SBR working here in Wexford General with Dr. Edna Harkin, who's a consultant geriatrician. And the case I'm going to present is entitled Atypical Ascites. So we'll do the case presentation, talk a little about underlying diagnosis, that the cause of this gentleman's presentation in the end, and then talk about ascites in general, how to work it up and what to do with it. And that's it. We'll do a little algorithm at the end. So JS was a 66-year-old gentleman who presented to Wexford General with a 4-week history of progressive abdominal distension and shortness of breath. He didn't have any fevers or cough, weight loss, he'd no altered bowels, and he didn't drink any alcohol and hadn't done so for the preceding 19 years. He passed medical history of atrial fibrillation, having had 2 failed cardioversions about 5 years, had a loop recorder in situ, hypertension, but nothing else really. He was on apixaban and ramipril regularly. And this was his first time being admitted to hospital. So on basic assessment, he was hemodynamically stable and afebrile. Fine, he was comfortable. No, he did have abdominal distension, which was tense with shifting dullness and some pitting edema to the mid-shin. He did have a regular pulse in the setting of known atrial fibrillation, but no signs of chronic liver disease or jaundice, no respiratory signs. JVP wasn't elevated, and he'd no palpable lip. So in his initial workup, his FBC was normal hemoglobin, his white cells and neutrophils normal with an elevated CRP of 122. His renal function was normal with normal electrolytes. LFT panel normal, and his CoI panel was normal. Just looking at his chest X-ray in the top right, a little bit underinflated because of the presence of gross ascites in his abdomen. Otherwise clear. You can just about see the little loop recorder there was present from his pre-monitoring. He had a PFA done as well, unremarkable. You can just about see the outline of his kidneys, otherwise unremarkable gas pattern. He did have an ultrasound abdomen then to assess, and it showed gross ascites, but his liver echo texture was normal. There was no focal hepatic abnormality, gallbladder normal, CVD non-dilated, kidneys, spleen normal, and importantly, his portal vein was patent. His retroperitoneum was obscured by bowel gas. So going to the top right, it's still from the ultrasound that was done on the day that he had his. So ultrasound is part of the HST GIM year. We do a course in point of care ultrasound. So things to look for in this that are remarkable are the outline of his liver is very smooth. So that moves you away from a diagnosis of cirrhosis where you'd see a craggy, uneven border. The echo texture then is just generally what the tissue looks like on ultrasound, and it should be similar to that of the kidney. So when it's similar to the kidney, the echo texture is normal. So it moves you away from a chronic liver disease picture. And then the black around the liver is just gross ascites. So that's the only real abnormality that was seen in his ultrasound, was that he did have clinically and radiologically evident large volume ascites. Then moving down to this cross section from his CT, you can just see again large volume ascites in the abdomen, in the peritoneal cavity, and then an unremarkable small bowel, and then there was nil else of note really. So We did an acidic tap, which is very important. We'll talk about that later. Obtained yellow colored fluid, which is easily obtained. He had a very high white cell count in that, but predominantly lymphocytic, with only 1% of PMNs or polymorphonuclear cells. Growth in the culture. LDH, protein, and pH were all normal in MASAG, or a serum to ascites gradient of less than 1.1. Serum albumin to ascites gradient less than 1.1. It was sent for cytology, so it's about 30 mils sent for cytology initially, and that's important. We'll talk about that again. See, in the setting of his history of atrial fibrillation, we did an echo to see if there was a cardiac component to the ascites, and it showed that he had non-dilated LV, good EF, 50-55%, small bit of hypokinesis in his anterior wall, major LVH. He had a predictably dilated LA in the setting of chronic atrial fibrillation. Nothing really else of note. The pelvis was done, whether there was a malignant cause. It was remarkable only really for gross ascites. The liver was small, otherwise normal, benign granuloma in segment 4. Gallbladder and spleen was normal, but no focal abnormalities, no lymphadenopathy. There's some fecal loading, prostate, no lesions in the lung, and bony windows were not. So still. So again, just looking at images from his ultrasound series. So craniocaudal length of his spleen at the top left was normal architecture. Just below that, then you can see the Doppler study from his portal vein, so showing patency of his portal vein. So this outruled Budd-Chiari or portal vein thrombus as a cause for his new ascites. His gallbladder here, empty and normal wall, and then moving. That's just the Doppler flow then, showing that it was good flow through the portal vein. Then up here, this is where you look for free fluid in the abdomen, and if you were to assess at point of care ultrasound where, if any fluid is present, it's in Morrison's pouch. So you put your probe down the right iliac fossa really, and you look for kidney and liver border. So what you should see if there's free fluid is a slither of fluid in Morrison's pouch here. You can see a slither of fluid as well then present in the abdomen. Outline of the liver, nice and smooth, good architecture, and a normal looking kidney. So what did we do with this fella? So he was commenced on Keptraxon originally because of a query of SBP given the high CRP. Came back as negative for that. He was commenced on diuresis, so spironolactone initially 100 milligrams a day with the addition of furosemide 40 milligrams once a day. Despite this, his weight was slow to budge and his symptoms remained poorly controlled, so a decision was made to do a large volume paracentesis. About 7.2 litres were drained under ultrasound guidance at the bedside. It was uncomplicated and well tolerated. Samples then were sent again for a cell count differential, but about 100 mils were sent this time. He was recommended on day 2 post. So where am with this fella? Does he have nephrotic? No, he had a normal dip with a normal EGFR, normal renal function, radiologically normal kidneys as well, and his 24-hour urine collection was within normal limits, so didn't have syndrome or any growth. Did he have TB? Interferon was negative, and the acidic sample didn't show any growth of any acid fast bacilli either. Did he have malignancy? By the image, what was the answer to that? Percent in any case. Needed normal CA 99, normal AFP. CA was mildly elevated 1.5 times the upper limit of normal, and his CA 125 was 3 times the upper limit of normal. Interestingly, his initial sample that we sent, which is about 25-35 mils of fluid, was negative for malignancy. It was a predominantly lymphocytic sample, and a diagnosis of cancer could not be made conclusively on that sample. We took his case to our local MDT, we reviewed his imaging, discussed the case. There was no convincing evidence of an intra-abdominal malignancy. It was suggestive of either malignancy, TB, or nephrotic syndrome, but there was little return from the workup. So it was decided that we should cardiac status and referred for a CAT to see if there was a constrictive pericardial component, and this was normal. And then we tried to get him a PET CT. The second cytology sample that we sent came back with a definitive diagnosis, however, for neoplastics expressed BRF4, CDX2, CEA, and CK20. It was negative for a number of markers, including synaptophysin and chromatogranin, which made neuroendocrine tumor less likely diagnosis. This gave us a diagnosis of a likely metastatic mucinous adenocarcinoma, likely colorectal in primary. After much over and back, and we finally got him a PET CT, which showed radiological evidence of cancer finally. So it showed a mental infiltration associated with uptake and moderate volume non-ascites. There was no increased uptake in the stomach, colon, or pancreas. So this suggested a diagnosis of primary peritoneal tumor. There's disease noted, and there was nothing above the diaphragm either. So here we are at the end then with JS, a 66-year-old male being diagnosed with primary peritoneal mucinous adenocarcinoma. This case was referred up then to the Peritoneal Malignancy Institute in the Mater Hospital. So briefly, a little bit about carcinomatosis peritoni. So this is the presence of malignant cells in the peritoneal cavity indicates that you have malignant ascites. It accounts for about 10% of all ascites, the majority of cause of ascites being either cirrhotic or cardiac in origin. Tumors that cause carcinomatosis commonly peritoneal deposits from ovarian, colorectal, pancreatic, uterine, or extra-abdominal tumors like lymphoma, lung, breast, a small number of unknown primary tumors. Survival in this patient population is generally poor. The literature will give you averages from 20 weeks from time of diagnosis up to 63 weeks with effective treatment. Treatment is often by centres such as the Mater, and it's cytoreductive surgery and hyperthermic intraperitoneal chemotherapy or supportive, with the goal of supportive measures to target symptoms, which include abdominal pain, dyspnea, nausea, anorexia, and vomiting. This photo from the bottom right is a publication from the institute published with their data from COVID recently, which just shows what they do. So you have a midline laparotomy scar here from a patient who has been treated surgically with cytoreductive surgery to try to identify any visible disease and resect it, and then they infuse a agent into the abdomen, close it over, and then put in drains. Obviously, Jürgen is the boss here, so I'll let him talk about it at the end. That's my limited knowledge of the topic. So ascites in general, when you get it, how do you decide what's causing it? So as long as there's been alcohol, people have been consuming it and giving themselves cirrhosis and causing complications. So it's been referenced in history as far back as 1500 BC. In the Old Testament, it was mentioned as a punishment for a wife's adultery, but not a husband's adultery, interestingly enough. Here you see a depiction in art from around 100 BC from Aztec times. So it's from Mexico days, depicting nowadays as well, a man with a big everted umbilicus, big distended abdomen, and then the sarcopenic arms and legs. In the top right, there's a depiction from 1600 in Germany with a fellow in an LVP or large volume paracentesis done. So big distended abdomen, a metallic tube going in through his umbilicus and draining fluid. These lads suffered quite a bit with septic shock, as you'd expect, but it's something that has been in existence for quite a long time. Terms like ascos, hydrops, and edema started to emerge in ancient Greece around 400 BC, and Hippocrates, the man himself, described the process of paracentesis, which literally aside, and he rapid paracentesis, saying vital or their vitality would suffer if you were too aggressive in your management. A famous person in history, Ludwig van Beethoven, underwent multiple paracentesis wine and had cirrhosis, but he died of a complication associated with this, which is SBP, where we are now. So ascites management principles, generally speaking, if you have someone with ascites, you have to grade it. So grade 1, 2, 3. 1 is just radiologically evident. Ascites 2 is and radiologically evident, and grade 3 is just large volume mass. So we initially sodium restriction to target 2 grams or 90 millimoles a day to try to achieve a net sodium loss and fluid loss. Fluid restriction is only indicated if you've got hyponatremia as well. Monitor their weight at the same time of the day, wearing the same shoes, aiming for 5 kilos per day as a target. The diuretics that we use, ascites, is spironolactone and fruit, starting at 100 milligrams a day for spironolactone and up 100 a day, and furosemide 40 up to 160 a day. You can taper and titrate to target, and you should stop it only if your sodium is less than 120 or potassium is greater than 6, or you've got progressive renal impairment or worsening encephalopathy. Large volume paracentesis is done for large volume ascites or people who are symptomatic with it. Should avoid NSAIDs, ARBs, or ACE inhibitors due to the risk of hepatorenal syndrome. TIPS should be considered in for large volume paracentesis or whose paracentesis is ineffective, like people who've loculated ascites. A diagnostic paracentesis should be carried out in all patients with cirrhosis and ascites on admission to rule. Very, very important. You should also do a diagnostic paracentesis in anyone who has ascites and who's sick with cirrhosis, just to outrule SBP as well. So there's multiple other reasons that are listed there. So how getting it? So again, point of care ultrasound is very important, just to identify some landmarks and safety zones. Epigastric artery runs lateral to your umbilicus, north to south. So you should go lateral to that, either in the right or the left iliac fossa. I usually go on the left because the spleen has to be massive for it to get in the way, where some people have an enlarged right lobe of the liver, which can be sometimes iatrogenically damaged by your needle. But again, you have to be quite aggressive to get at any sort of organ damage. So anybody who comes in with new ascites, worsening ascites, or it's not contributed in coagulopathy. So the only reason you would not do it is if they've overlying cellulitis in the area of skin where you're thinking of sticking your needle infection into the abdomen. There's caution only recommended in thrombocytopenia. So if you've got somebody 50 or less and they've DIC, you wouldn't do it. If you've got an elevated INR, it doesn't matter. You can tear away. It's a procedure. It's very safe, low incidence of complications. The risk of bleeding is between 0.1 and 0.9%, even in patients with coagulopathy. So it doesn't matter what their INR is. You can tip away and be reassured by the fact that it's a small needle, very unlikely to cause any. You can use an ultrasound to guide the placement of the needle, and the Z technique is what we advocate to use translocation of back, just altering the angle of your needle, the peritoneal cavity to reduce elongation. Very important point that if you delay doing the paracentesis at any point or diagnostic because you think, gosh, we'll wait till morning, it'll be grand. Every hour you delay it, there's a 3.3% increase in mortality per hour from time of presentation. And this equates to 2.7 times the risk of mortality from SPP 12 hours after admission. So this is borne out and very, very important to do. So fluid, what do you do with it? So the FBC bottle is for your counter differential. Your blood culture bottles are for culture and sensitivity, and then your biochem bottles are for the rest, so your albumin, protein, etc. Cytology then goes in a sterile container, and there's much conversation about how much do you send, what's the optimal value. So there was a group from the Saudi Journal of Gastroenterology recently looking at this very question. So the count was between 100 mils is optimal. Any more than 200 mils is reasonably unnecessary to get the diagnosis from. Around 150 mils of fluid, you're probably wasting the histopathologist's time by sending them more fluid, but you're wasting your own time and the patient's time if you're sending less, because you're not going to get the diagnosis. Finally, this is an algorithm from the American Association of Study of Liver Disease to guide the workup of people with ascites. So you start off at the top with your diagnosis, and then the SAG, you go next. So a SAG of greater than 1.1, you look at acidic protein. If it's less than 2.5, it's likely cirrhosis, and this is confirmed on abdominal imaging with elastography or FibroScan being another option to show that the liver is fibrotic. Acidic protein greater than 2.5 will be post-sinusoidal, so you're looking at your hepatic vein, your portal vein, and an echo to reason, so thrombus or Budd-Chiari, etc. SAG of less than 1.1, you're looking at a possibility of peritoneal disease. So it could be nephrotic syndrome, TB, or peritoneal disease. So you look at cytology, you look at your acid-fast bacilli, and then you do abdominal imaging to screen for cancer. If you need to do laparoscopy or peritoneal biopsy. So those are my references. Thanks very much, and I'll happy to answer any questions that you might have.
Fantastic. Thanks very much, Alan. That was great. I particularly enjoyed the historical context as well. It's amazing to see the sculpture that's like such a typical representation of ascites so long ago in the past. We'll go to Jürgen in a second, but just a quick question about the point of care ultrasound. I mean, it's not that long since I was doing this without any possibility of having an ultrasound, and that was considered standard of care. And is it fair to say that now you really would get an ultrasound every time you're putting a needle in, or that at least it's available if you wanted it?
Yeah, I suppose you don't really need one for patients who are coming into with tense, like frankly, distended abdomens. It's very safe to proceed with doing a diagnostic tap in those patients. For doing an LVP or putting in a drain, it's now recommended as a standard of practice that you do use ultrasound to guide where you go to try to avoid major landmarks like liver, spleen, kidneys if you're that far down, and the inferior epigastric artery and other vessels are easily identified on Doppler studies. So when I started doing gastro back in the day, I used to go down to A&E and get their portable ultrasound and wheel it around the wards. But now we're using our own point of care ultrasounds. You can get a Butterfly or a Philips Lumify. So there's a butterfly knocking around that one of the SBRs here has as well, and I'm on the waiting list to get a Lumify, Philips Lumify. So it's moving towards getting your own little point of care ultrasound, but at very least trying to get a portable down to have a look.
Yeah, that's fantastic. Actually, Tomas is here as well, who's a consultant in emergency medicine. And Tomas, you have an interest in focus as well, isn't that right?
Yes, thanks, Shane. And just for those of you who weren't aware, the RCPI have introduced a course which is now mandatory for all GIM SPRs. So SPRs in their GIM year, which is basically procedural ultrasound guided procedures, essentially. So the, as Alan said, with somebody's got a very big tense ascites, you know, you could argue you don't need it, but certainly the principle that nobody should really be sticking a needle into any part of anybody's body without being sure where they're going with ultrasound. And certainly we teach it for aspirating pleural fluid, doing LPs, get difficult vascular access, central vascular access. You can use it for taking fluid from joints, arthrocentesis, and as Alan said, it's useful to identify the inferior epigastric artery, so you don't go through that with your needle when you're draining ascites. He just raises another interesting point there, when about the delay in TAP, because and who should do it? Should emergency medicine do it? Should gastro do it? Should IR do it? Should medical reg on call do it? So it's interesting that the sooner the better. It's like everything else in medicine. But I'd like to hand over to Mr. Jürgen Mulslow now, maybe just to tell us about the HIPEC service and the matter. Even though I work there myself, I haven't seen it, and I'm very curious to learn more about it. Thanks.
Thanks, Tomas, and thanks, Alan, for your presentation, which I enjoyed. I think it summarized and clearly told a story which we see often, in that it can be difficult to make a diagnosis in these patients. I think there may have been one clue in your CT at the outset which showed that the small bowel was compartmentalized in the posterior abdomen rather than floating free within the ascites. And we often see that with peritoneal cancer. When they're studying the mesentery, it becomes cicatrized, less mobile, and drawn into the back of the abdomen. That might have been a clue. But as you rightly show, it's often difficult to diagnose these patients. It's interesting that CA19-9 was normal, because it's a fairly non-specific marker of peritoneal tumor, but it's nearly always elevated in these patients. But in your case, it was normal. Most patients with peritoneal cancer, it's a metastatic phenomenon. And in a male patient, I don't think I've ever seen a primary peritoneal cancer, aside from peritoneal mesothelioma, which we only see about 5 of a year in Ireland. You do see primary peritoneal cancer in females, but again, that's very rare, maybe 5 to 10 a year in Ireland. So this patient's cancer is almost certainly coming from either their appendix or their colon or rectum. Other causes potentially would be the stomach, pancreas, but I think your markers suggested a lower GI source, and it's probably from the appendix, particularly if we're not seeing it primary on the CT in either the colon or the rectum. And as you've rightly said, these patients can be very difficult to treat. And you've mentioned cytoreductive surgery and HIPEC, and that is something we do. But I wouldn't like to give your audience the impression that that is something that all patients with peritoneal cancer will have. We've done about 400 operations like that, but we've turned down double that number of patients, because we have to be very selective about who will be likely to benefit from what can be a lengthy and potentially risky and morbid operation with a long recovery period. But the aim of the surgery is to clear all macroscopic tumor, and that can be a significant undertaking, including removing all of the peritoneal lining of the abdomen and pelvis, the colon, the rectum in the female, the ovaries, uterus, the spleen. We may have to do a partial gastrectomy. We have to mobilize the liver and take the capsule of the liver off. So it's a very long, potentially morbid procedure, and we have to be careful that the patients we subject to that type of surgery are going to benefit from it. Then once we've done that surgical cytoreduction, in other words, we removed the macroscopic tumor, we combine that with the HIPEC, and you showed a picture of that. And HIPEC is hyperthermic intraperitoneal chemotherapy. And the idea behind the HIPEC is that we presume there is residual microscopic disease within the abdomen. We hope that the HIPEC, through direct contact with that cancer or those cancer cells, will eliminate those cells. And that's given us a single treatment at the end of the operation. So we've done the surgery, and we then deliver HIPEC, heated chemotherapy, using a perfusion system. And you showed a picture of it. The technique you showed was a closed abdomen technique. We often do an open abdomen technique as well. But either way, you're delivering heated chemotherapy into the abdominal cavity, and it's circulating at high flow. The reason we heat it is that the data we have suggests that heating increases the chemo penetration and also the cytotoxicity. And we deliver that for typically an hour. Now, you might say, why an hour? It's somewhat arbitrary, but that's a fairly standard algorithm, and we followed one which is followed in a lot of the bigger centers, particularly in the UK, where they have the biggest series in the world. It's given as a heated treatment for 1 hour, then we wash away the chemotherapy and the abdomen is closed. So the cytoreduction is augmented by the hyperthermic intraperitoneal chemotherapy, hopefully to achieve a complete surgical cytoreduction, in other words, to remove all tumor. The outcome thereafter will be very much dependent on the primary tumor and its aggressiveness, and it can vary greatly. So we can achieve cure in patients with, for example, with pseudomyxoma from a low-grade appendiceal mucinous tumor, even if they've got a very high disease burden. But on the other hand, a patient with a colorectal cancer with multiple adverse features and even a low volume of tumor is very unlikely to get long-term survival. We may be able to improve their survival and also improve their quality of life. So that's a very brief snapshot of it. It's a very selective treatment, and I would say that it's also very much part of a multimodal treatment. Most of our patients will have interaction with their oncology colleagues either before or after. This is cytoreduction on its own is rarely employed, certainly for colorectal cancer.
Fantastic. Thanks very much, Jürgen. Really helpful to get that background and context. And Alan, was there anything that you wanted to mention in response?
No, that's very useful. Thanks very much for the input. I suppose, Jürgen, that's something that I would have very limited to no experience with. Very rarely would myself as a gastroenterologist encounter these patients, but it's great to hear that that's where they're sent and how they're managed. I'll be in the Mater in July, so I might give you a wave. And Thomas, I suppose the answer to your question is who should be sampling these patients. I would just be keen that they are referred as early as possible. Anybody with ascites, by definition, is decompensated in terms of their liver disease and needs to be seen and sorted as early as is possible, because the first 24 hours really is crucial for their care, and their mortality is obviously quite high at baseline, but the earlier you can intervene, the better. And I have this adage that you seek and treat infections, and especially SBP. So either the ED team or the medical team, either or, and I've worked in both settings, so I know the pressures both are under on call, should be confident and competent enough, especially given the low rate of complications, to stick a needle in. With or without ultrasound initially, it's very safe to do so. But if you're draining, obviously use ultrasound. But whatever, it doesn't matter as long as it's done so.
I think one of the anxieties in doing these kind of things is knowing exactly what to send, what bottles to, where to send it to, what to request. So it'd be fantastic to put together a kind of a pathway, an easy dummies guide to sending acidic fluid to the lab.
Alan, in the patient with a suspected malignancy, a laparoscopy is nearly always going to give you the answer in all directions, because obviously you can sample the fluid, but you can also biopsy, but perhaps more importantly, you can assess the distribution of the tumor. And in someone who is experienced in looking at that type of thing, and that'll be most gastrointestinal surgeons, they'll have a fair sense as to whether or not this is something that's ultimately likely to be suitable for consideration for surgery and what direction it needs to take. So if you sense malignancy, a laparoscopy can be a good option if the patient is fit enough.
Is there any centres you would recommend to refer these people to, just to speed up the process? Because when you're working in a tertiary referral centre, grand, you might have colleagues who are confident doing that, but somewhere in the peripheries like Wexford or Mullingar or wherever, is there anywhere you would recommend, or any pathways that are in place for those patients here?
Well, look, we're always very happy to look at these scans and to try and help it in as timely a manner as we can do. And if we are considering a cytoreduction, we'll laparoscope these patients ourselves, and we do that every week. So we're happy to do that. But then likewise, you have your colleagues in Waterford or in Cork or in any of the major centres in Dublin who will be able to perform a laparoscopy if that's what's required to achieve a diagnosis. But we're very happy to consult on any of these patients.
Fantastic. Alan, does Dr. Harkin want to come in with anything there at the end, just to give you the opportunity?
I'll pass it down to her there.
Well, I'm a geriatrician, so actually I was even more at sea with this than my gastroenterology SPR. I suppose from our point of view, when we started looking at this guy, he obviously had ascites that was not going to be straightforward when we realised he had cirrhosis. And from people working in a DGH, sometimes we struggle to, now we did get the diagnosis on this guy, but it actually proved, it all looked very smooth there as Alan presented it, but actually it took quite a lot of negotiating to get the PET scan done, and the cytology actually came back after the PET scan. So from our point of view, sometimes we feel we have to get a full diagnosis before we can refer, because actually we'd had a discussion about what we were going to do with this guy if the PET scan and the cytology yielded nothing. So if anyone had any ideas, if we had a similar case again where we didn't have a diagnosis, where we could have referred him.
Okay, so maybe we could pass that on to Jürgen. Would you have any comments on that, Jürgen?
Well, again, if there's any sense at all that it's a malignant process, then I think it'd be useful to involve a surgeon. And certainly, if the patient is fit enough, then a laparoscopy will give you an answer straight away. And you know, you've got very experienced colorectal colleagues down in Waterford. They would, I'm sure, be very happy to do that. And likewise, if there's if you have a clear sense that this is a malignancy, we're very happy to get involved. And we laparoscope these patients very, very frequently. So I guess what we couldn't do is provide a blind service for all patients with undiagnosed ascites, but certainly once you're clear that there's a malignancy going on, we'll be very happy to get involved.
Okay, thanks very much.
Cheers.
Fantastic. Great. Okay, Alan, will we finish up there and pass over to Luke?
Yeah, I'm just going to load up his presentation here now on my computer, and we'll change the name on the Zoom to Luke.
Fantastic. That's great.
Thanks very much for that, Alan. That was very comprehensive, and thanks very much, Jürgen, for coming in on that. Really good case.
Right, I think I have it now. Now, I'll start screen sharing there, and you can let me know if you can see Luke's presentation there as well.
Yeah, perfect. We have it now. So Luke, thanks very much for joining us. You're a cardiology SPR in Wexford and just coming off your night shift, is that right?
Just coming off a week of nights, yeah.
Yeah, fantastic. That's amazing. Thank you so much for joining us. Right, so you've got a fantastic case about the collapse of a young woman.
Yes, so I'll go ahead. So yeah, my name is Luke. I'm one of the cardiology SPRs working in Wexford with Dr. Michael Reardon. So this is a case I'd like to present entitled "The Eyes Have It, Collapse of a Young Woman." Before I start, I'll just say that we do have informed consent from the patient to use some pictures during the presentation. So a 28-year-old lady was brought in by ambulance after being found unresponsive at home. She was previously well prior to the presentation and was found unresponsive at 8:30 in the morning by her mother in her bedroom. On arrival to the ED, her GCS was 7 out of 15. She had some intermittent myoclonic jerking. The collateral history revealed only a past medical history of anxiety, previous diagnostic laparoscopy for an ovarian cyst, and she was recently commenced on the oral contraceptive pill. She didn't take any other regular meds, a non-drinker, non-smoker, no recreational drugs, no significant personal or family history of note, no recent travel, sick contacts, tick bites, or features of connective tissue disease. No head trauma preceding the event. She wasn't on anticoagulants, and she had no evidence of bleeding diathesis. On exam then, she was drowsy and unresponsive. GCS was 7, scoring 1 for eyes, 5 for motor, 1 for voice. A limited neurological exam revealed evidence of anoscoria. So right pupil measured 4 millimeters, left pupil 3 millimeters, and she had a sluggish pupillary response to light. Intermittent generalized myoclonic jerking was noted during the examination. She was lip smacking. She had bilateral upgoing planters, and evidence of left hemiparesis was noted. The rest of the exam was within normal limits, and hemodynamically, her vitals were all normal. In terms of her initial assessment in the emergency department, her ECG showed normal sinus, no evidence of atrial fibrillation. There was some P pulmonale noted in her inferior leads. Dipstick was normal. She was not hypoglycemic. BSL was 5.4. Gas was normal. So she was referred to medics, and she had an immediate CT brain performed, which was normal. So just thinking about the case so far and thinking through the differential, is that previously fit and healthy 28-year-old lady with no significant past medical history, no significant family history, rapid deterioration in her GCS, presenting with 7 out of 15. She's anoscoria, left hemiparesis, bilateral upgoing plantars, myoclonic jerking and lip smacking is noted. She's taking the oral contraceptive pill, which was recently started. Her CT brain is normal. Her initial lab work is normal. Her mother was in the department at the time, who showed us a selfie that was sent to her by the patient 30 minutes prior to being found collapsed. And that's what the selfie showed there. So you see evidence of bilateral ptosis. So the patient went on to have an immediate CT intracranial angiogram. And I don't know if you guys can appreciate the abnormality there in the basilar artery, which is occluded. So the diagnosis of acute basilar artery thrombosis was notified to the medical reg and call at 11:10. Her NIHSS was 6, but most parameters were untestable. She had no contraindications to thrombolysis, and as such she was commenced on alteplase at 11:23. She underwent immediate discussion with neuroradiology in Beaumont, and she was accepted for transfer for mechanical thrombectomy. She was intubated and ventilated prior to transfer due to a GCS of less than 8. So in terms of basilar artery stroke, 1/5 of strokes occur in the posterior circulation supplied by the vertebral basilar arteries. And a basilar artery occlusion accounts for the most catastrophic subtype of posterior circulation strokes. A mortality rate of greater than 90% is reported in untreated cases. And 24% of patients will have a good outcome. So that's a modified Rankin less than 2 and Barthel index 95 to 100. In terms of management of this syndrome, high quality randomized data is lacking. And that's just a diagram there of the anatomy. So it's formed by the joining of your 2 vertebral arteries. Important branches include your anterior inferior cerebellar artery. You have penetrating pontine arteries, superior cerebellar artery, and posterior cerebral arteries. It begins at the medullopontine junction and ends at the junction of pons and midbrain. It supplies blood to your brainstem, your cerebellum, thalamus, medial, temporal, and parietal lobes. Your penetrating arteries supply your paramedian pons, and your pontine tegmentum is supplied by your distal basilar artery. It's important to note that your lateral pontine tegmentum is supplied by your pica, which comes off your vertebral artery, so it's spared in this syndrome. In terms of how it presents then, the paramedian pons contains descending motor fibers and crossing cerebellar fibers, and the paramedian tegmentum contains your oculomotor fibers. So these patients typically present with motor and oculomotor findings, but I'll discuss that a little bit more in a minute. Sensory and vestibular tracts are contained in the lateral tegmentum, and they're normally spared in basilar artery occlusion. So more than 50% of cases are atherosclerotic, and these normally present with occlusion of the proximal 2/3 of the basilar artery, in contrast to embolic disease, which could be due to vertebral artery dissection, or cardioembolic stroke tends to affect the distal basilar artery. It presents in 3 major subtypes of clinical presentation. So you may get sudden onset severe motor and bulbar symptoms, as was in this case. Patients may present with gradual or stuttering symptoms, or you may get transient prodromal symptoms, which precede severe symptoms by several days and sometimes longer in certain case reports. So what to look for on examination? The patient will have reduced level of consciousness, coma. They may have evidence of hemiparesis, but there is also motor and reflex abnormalities on the non-hemiparetic side. So we can see that in this case where she had bilateral extensor plantars. They tend to get spontaneous jerking, twitching, and shaking that normally affects the non-hemiparetic side. They have asymmetrical limb ataxia. Bulbar symptoms are important: dysphonia, dysphagia, dysarthria, facial palsies, and ptosis, as in this case, and also oculomotor palsies. So how do we treat it? As I said earlier, there is a lack of randomized, good quality data for the management of basilar artery occlusion. This leads to variation in different stroke protocols in different centers. In terms of the most important thing with treatment, early recanalization is really the goal here. So your options include intra-arterial thrombolysis, which is implemented in some stroke centers, but not in most, or intravenous thrombolysis, which is a lot more readily available, but is associated with less frequent recanalization and more systemic bleeding. However, it can be given without delay. And just a study by Pertu et al. Showed no significant difference actually in survival and good outcomes comparing intra-arterial and intravenous thrombolysis. Recanalization was more frequently achieved with intra-arterial thrombolysis. And if you don't recanalize the basilar artery, your likelihood of a good outcome is 2%, so pretty catastrophic outcomes. And you're more likely to recanalize if you thrombolize early. It differs from anterior circulation stroke syndromes in the sense that salvageable tissue extends beyond standard time windows for thrombolysis, so outside of your 4.5 hour cutoff. Studies suggest slower progression of ischemic tissue damage, and as such, you should perform perfusion imaging with diffusion-weighted MRI to characterize salvageable tissue. Intravenous thrombolysis protocols differ greatly between different centers. Most centers offer thrombolysis within 12 hours of symptom onset, but in some places up to 2 to 3 days in select cases. So how does thrombectomy fit in the management? So most large-scale trials on thrombectomy excluded posterior circulation strokes from analysis. So most of the studies we have on thrombectomy for basilar artery occlusion are limited by small sample size and heterogeneous patient populations. There was a study performed by Kang et al. Which showed successful reperfusion in 91.5% of cases and a modified Rankin less than 2 and 44.8. Mortality was only 16% of the study, and 30% of patients were thrombolized. Patients with diffuse pontine ischemia and diffusion-weighted MRI were excluded. And it's important to say just thrombectomy was only offered within 12 hours of symptom onset. That may affect the results somewhat. So back to our case, the patient was immediately transferred to Beaumont for thrombectomy after initiation of thrombolysis. She had an emergency MRI performed in the thrombectomy suite, which confirmed recanalization of the basilar artery. She had an invasive angiogram which showed the clot had dispersed, so there was no attempt at thrombectomy or clot aspiration. So she was transferred to the neuro ICU, where she was extubated the following day with a day 1 NIHSS of 1. So her MRI brain showed acute infarcts in her anterior left thalamus, medial right thalamus, paramedium right midbrain, and left occipital lobe. As she's a young embolic stroke, she underwent full ESOS workup. So she had a TOE which showed an aneurysmal intraatrial septum with PFO evident on color Doppler with left to right flow. She had a positive bubble study with Valsalva indicative of a right to left shunt. She underwent 24 hours of cardiac monitoring. There was no evidence of atrial fibrillation. ESR, lupus anticoagulant, antiphospholipid antibodies, lipids, HbA1c were all within normal limits. Patient had an excellent recovery while an inpatient with minimal residual neurological deficit. Her PNS exam was normal, except for minimal ataxia, and her CNS exam showed the following. So hopefully this plays. So you guys can just appreciate the right-sided INO at the start of the video. So she is left with the residual right-sided INO, which is much improved, but no other debilitating neurological deficit. She is awaiting PFO closure in Beaumont Hospital. She did have an attempt at closure, but it's complicated by her PFO tunnel size. She was for a repeat attempt with a Cardioform Amplatzer device, which is quite a large closure device, so quite specialized in terms of closure. She was discharged on aspirin and clopidogrel for 2 weeks and subsequently switched to a Pixaban 5 milligrams BD and a torvastatin 40 milligrams. And it goes without saying that her oral contraceptive pill was stopped. So in terms of PFO diagnosis and stroke, there was a good consensus statement from the 8 European societies published in 2019, which is a good read for anybody who's interested. So they recommend transcranial Doppler as it has a higher sensitivity than a contrast transthoracic echo in diagnosing a right to left shunt. TOE, I've seen it in a lot of centres, is used for the initial diagnosis. However, really it's recommended to characterise the anatomy to establish the need for closure and to find any high risk features that would be associated with stroke recurrence. A sensitivity for PFO is reported at 89% with TOE. This is likely due to difficulties in performing the Valsalva maneuver in sedated patients. So what do we look at when we do the TOE? We want to characterize the severity of the shunt, so the number of microbubbles crossing the intraatrial septum, whether the septum is aneurysmal, which is significantly associated with a causal row of the PFO and stroke recurrence, and also your PFO morphology to guide closure. Other things such as eustachian valve and Chiari network are associated with recurrence as well, but the evidence isn't as strong. So who should do TOEs? It should be performed by an experienced operator who knows what they're doing, as small and low velocity shunts will be missed if incorrect settings are used. It's important to perform a bubble study correctly as well with the Valsalva maneuver to assess if there's any right to left shunting, and this is difficult with sedation. So bubbles crossing the intraatrial septum within 3 cardiac cycles is in keeping with the PFO. And this is just the ESC diagnostic algorithm that's suggested. So either a contrast TTE or contrast transcranial Doppler, favoring a transcranial Doppler to assess for right to left shunt. If it's positive, then to move on to TOE to further characterize the anatomy. And this is just what PFO looks like. So this is a TOE image in the mid-esophageal view. You can see malapposition there of the septum primum and septum secundum with a PFO. I don't know if you can see my cursor there, but it's just it there. So PFO management is quite complicated, and it should be managed in a multidisciplinary clinic with both cardiology, neurology, and stroke medicine present. The reason for this is 25% of the population will have a PFO, so delineate the role of PFO in causing a stroke can be quite difficult. So what do we do when we're seeing these patients? We want to characterize the probability that the PFO caused a stroke and also establish the risk of further stroke recurrence in the patient. Patients with both high probability of a causal role and high risk of recurrence should undergo closure. However, patients at low risk can be managed with antiplatelets or antithrombotic therapy. As always, patients are managed on a case-by-case basis. This is just a wordy slide taken from that ESC consensus paper on the management, so I'll just focus on some of the important points from it. So cortical infarcts are commonly embolic, but white matter infarcts may also be embolic as well. The presence of an aneurysmal atrial septum, a severe shunt, and septal hypermobility are linked with a causal row of the PFO. Concurrent simultaneous pulmonary embolism or DVT strongly suggests the causal role of PFO, and risk factors for DVT occurring around the time of stroke are also associated. So recent immobilization, long car journeys, dehydration. And in terms of establishing the risk, they say here the risk of recurrent embolism is low, but it's 1 to 5% depending on what studies you look at. Variables linked to a higher rate of recurrence are an aneurysmal atrial septum, large PFO, older age, coagulation disorders, elevated D-dimer, and antiplatelet versus anticoagulant with higher risk of recurrence on antiplatelet therapy. And this is the ROPE score, the risk of paradoxical embolism score, which may be implemented in these cases. So you look at the traditional risk factors for stroke and look at the patient's age. So patients with no risk factors for stroke and at a young age score higher. So patients with a, say, score of 9 have a PFO attributable fraction of 88%. So it's a lot more likely that their PFO is causative. That's what the device looks like. So that's an Amplatzer septal occluder device with a left atrial disc larger than the right. And that's the other device that's used, the Gore Cardioform occluder device. That doesn't come across great, but that's what a Amplatzer device looks like when it's implanted into the intraatrial septum on fluoroscopic image. So in terms of the evidence, there is some data. The RESPECT and the REDUCE trial looked at the Amplatzer and Cardioform devices respectively. These were patients with PFO and previous stroke, and they compared PFO closure with medical therapy. For the most part was antiplatelet therapy. In the RESPECT trial, there was a significant reduction in stroke recurrence with a hazard ratio of 0.55. And also in the REDUCE trial, there was a significant reduction in stroke recurrence. The CLOSE trial was done in 2018. And this looked at more specified patient population, so patients with either a large PFO or an aneurysmal atrial septum. So 0 patients in the PFO closure group suffered from stroke at 5 years follow-up versus 6%. I think there was 300 in each group in medical versus medical therapy. In terms of meta-analysis looking at antithrombotic therapy, there really is only 3 randomized controlled studies that looked at antithrombotic therapy, but there is suggestion that PFO closure does reduce the risk of stroke occurrence with antithrombotic therapy. And this is just some of the meta-analysis data. So if you just look at the top there, we're looking at freedom from stroke. And we can see here on the left is favoring closure and on the right favoring medical therapy. So we can see in all groups there is a trend towards favoring closure. However, if you divide those patients up into those with a large shunt and those with a small shunt, we can see the evidence is a lot stronger for patients with a large shunt for PFO closure versus those with a small shunt. So what to conclude from this case, early recanalization with intravenous thrombolysis and early transfer to a neuroradiology center is essential in the management of these patients. Thrombolysis should be considered outside the 4.5-hour window implemented for anterior stroke circulation syndromes. We need more randomized data to guide management in terms of both thrombolysis and thrombectomy for patients presenting with basilar artery occlusion. I've just touched on a few things, but just stroke workup for embolic stroke of unknown source include transthoracic echo, contrast transcranial Doppler, contrast transesophageal echo, and cardiac monitoring. Management of PFO closure or PFO related embolic stroke is complicated and it's best coordinated in an MDD clinic with neurology and cardiology. Patients with larger shunts seem to derive the most benefit from closure. And just think of basilar artery occlusion in patients presenting to the emergency department if you're on call with a reduced GCS, and just keep in mind some of the symptoms that Our Lady presented with. So that's the case, and thanks very much for listening.
Fabulous. Thanks very much, Luke. So very good outcome in the end. And I'm sure she was very grateful for everything that she received. Had she already started to improve after the thrombolysis before she was transferred to Beaumont?
No, I don't think so from reading through the notes.
Yeah. It's interesting because it must be about a 2-hour travel time, is it, up to Beaumont from Wexford?
She was intubated and ventilated
yeah.
over GCS was 7. So it's hard to say, with day 1 in the HSS of 1, but they didn't do the thrombectomy or clot aspiration in the end. It's the thrombolysis that dispersed the clot. So I imagine there was some neurological recovery while she was sedated and intubated. Yeah.
Fantastic. So I might bring in Prof. Tim Lynch, who's Chief Clinical Academic Officer with IEHG and Consultant Neurologist. Tim, any comments on that?
Thanks, Luke. Nice outcome. Yeah, the intravenous thrombolysis, you did well with that. Often the basilar clot doesn't actually break up and lyse with the intravenous one. It's often due to clot volume, is thought. So you do often need thrombectomy. So nice job. That was a good outcome. So it's clinically, just comment from a neurology viewpoint. I mean, the collapse coming in at 28-year-old after doing the usual stuff that Tomas sees all the time in the matter of drug overdose and diabetics and low sugars and post seizures, blah, 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 blah. And you do all that sort of screening. But why is she down is the question. And I suppose from a neurology viewpoint, managing these cases is key. The first thing I was asked is where in the system is the problem in neurology? So, if somebody's collapsed and you've got a clue then in the exam, you've got pupil abnormality, you've got left hemiparesis. So you're getting up either at your spinal cord possibly, or your brainstem or brain. And then the CT brain is helpful because it's normal. Now that's like Sherlock Holmes, the dog that didn't bark. Why is the CT brain scan normal? If she's got a stroke with unresponsiveness, that's hemispheric, it should be bilateral. So there's a great book by Plum and Posner called The Diagnosis, Stupor and Coma. Should be all in ICUs and all in A&E departments because it defines how to assess people in coma in regard to the examination. And it's really key, the history and the examination. That book is really helpful as regards to the proper assessment examination of pupil response, breathing patterns. Her breathing pattern would be abnormal during this. She may have a Cheyne-Stokes or some other breathing pattern, which again, you're hunting, looking for how to localize this problem. The key then, of course, is the selfie. God bless the mobile phone. The biggest development in neurology is not the MRI scan, it's the mobile phone, because we can take a history from people and mom comes in and saves the day. because remarkably, she takes a selfie of herself an hour before collapse. So now you not only know the time when she collapsed, your thrombolysis, thrombectomy is all feasible, but also she got bilateral ptosis. Why? So bilateral ptosis, really, you start hunting and you start thinking neuroanatomy, back to the old neuroanatomy. And either you're dealing with myasthenia gravis, but then she shouldn't be collapsed in coma, or you're dealing with something else. And you look at the third nerve nucleus, you love your neuroanatomy back to college again, and the central third nerve nucleus is a bilateral innervation to the levator papilla superioris. So if you take out your third nerve centrally, it's one nucleus, supplies both sides, bang, both go down, and both pupils will become abnormal, and both our pupils are abnormal. Sometimes they're blown, but this stage you just can analyze a cornea, they're not responsive. So she's at a central hit, posterior midbrain, where the third nerve nucleus sits there. It's a very complex nucleus, a lot of subnuclei, some are bilateral innervation, but the two that innervate both sides is the pupils and the levator palpebrae superioris. So on that exam, I say brainstem straight away, and it's top of brainstem, it's posterior, it's dorsal midbrain, and beyond up the thalamus. And you know that before you go anywhere else. And then what is it is the next thing that neurologist asks, and you go down to your list. Is it, stroke, inflammatory infection, acute onset here, young woman, obviously you're thinking along the line of stroke, you have a third nerve nucleus, so you've had a stroke, that's telling you in that area. So then it's got to be basilar artery, because that's what supplies that region and causes collapse. Other comment I would make is an MRI scan availability is becoming more and more important. This is a problem. We have a problem as well, even in the matter. I can struggle to get MRI scans at weekends. And we do need that device in the assessment of these correctly and properly, particularly deciding thrombectomy is a salvage or not. So I think we're going to find that they're going to have to be available in MRI scan that's available to the A&E department of the hospital 24/7. That's going to have to happen in the near future, and we're going to have more and more legal cases when this is done. During that assessment, you commented, I think you're right, the BAS are a bit more tricky than the regular ones, when to go in after thrombectomy. And often we're looking very carefully to see actually what's the circular willis like. Because if you think about it, you've taken down the vertebral basal circulation, but maybe you've got good PCOMs coming off the back of the circular willis supplying the superior cerebellar artery, the posterior cerebral coming down to the basilar, and you might spare the midbrain. So the collateral supply assessment is very important, and you can get a good assessment of the CT angio or the MRA. So often we look at that, and that can often give us a hint. Well, actually, maybe this is salvageable or not. So, well, the nice, yeah, the clinical stuff gives you the clue. You've got a nice combination of the history. Mom's selfie saves the day, the exam, plus then the CT, the normal CT brain scan, brainstem, because it should be collapsed bilateral hemisphere. You should see something otherwise. You might have a dense basilar artery sign that's usually missed, and you really have to look at the scan yourself. So the axial cuts, as you're going at the vertebral basilar, sometimes you see some density in the basilar that's more than usual. Now that's tricky because in an older person, you might get calcification of the vessel. It looks dense, but a 28-year-old, she'd a dense basilar artery, and I would be hinting that area. So I'd be interested in looking at the axial cuts through the brainstem would be helpful. That's all I have to comment.
Fabulous. Thanks very much, Tim. The mini tutorial. We're all up to speed now.